Hello and welcome to the IdeaCast interview series, episode number 166. My guest in this episode is Dr. David A. Kent, and Dr. Kent is a board-certified psychiatrist with over 35 years of clinical experience. He's also the founder of the NuMe TMS Clinics in Idaho. We'll be talking about that. He specializes in this work. He specializes in brain stimulation for treatment-resistant depression. And I had initially scheduled, or was intending to schedule a pre-meet with Dr. Kent, and we just got together on a Zoom call and hit record, and there was no pre-meet. So this was a nice, off-the-cuff kind of conversation. I am going to have him back as a guest in the hopefully near future. He has a book called Why Me? Your Brain on Tilt, which tilt is a poker reference, as you'll find out in this conversation. I plan to read the book and have him back, and we'll speak to the contents of that book. So it was a great conversation, despite my not having any sort of material to ask him questions. But that was fun to do it that way. So thank you so much for being here. I appreciate it, and I hope you enjoyed this first of two conversations that I will have with Dr. Kent. And I'd like to welcome Dr. David Kent to the IdeaCast interview series. I'm improvising tonight. I didn't do much, confessing to not having done much research of Dr. Kent's work, but that's fine because Dr. Kent is going to be able to carry himself very, very well and very competently. So I'm just going to do my best to be a nice host and ask half-decent questions. So welcome to the audience as well. And Dr. Kent, welcome. Glad to have you here.
Thank you. I appreciate being on.
Yeah.
It's a pleasure, of course.
Yes, it is on my end, especially because I am very much concerned about human flourishing, well-being, the state of our psycho-emotional, both individual and collective condition. And I think a lot of my audience comes here for that as well. As I mentioned to you before we hit record that a lot of my guests, they orbit around these ideas of well-being, sense-making, meaning-making, all this kind of thing. So I think you and I are going to have a good informative conversation. So what I guess would be good to do for the audience as well as for myself is to check in with you about your background and your history and where you're coming from. And then you have a book that we should talk about. So let's start with you and then we can open up and talk about the book.
Sounds good. I can always talk about me. No problem. Me.
Yeah.
Well, I'm a psychiatrist. Some people get confused on what that means. A psychiatrist is a medical specialty. So you have to kind of go through some college and then medical school for 4 years. And then in psychiatry's instance, if you do adult psychiatry, it's 4 more years. So it's 4 years of a psychiatric residency, they call it.
Okay.
I'm from Iowa originally, and I grew up in Iowa City, which is the University of Iowa's. That's the town I grew up in. So I grew up in a university town surrounded by highly educated people. In fact, I felt a little bit, I don't want to say dumb, but I didn't feel like I was as smart as a lot of people around me. So I had to kind of work hard to get where I was at, to kind of catch up to people because I was around a lot of smart people. Okay. So I grew up in that setting. When I was in high school, I had the fortunate opportunity to, I knew a world famous heart surgeon who knew our family, and he invited me to go watch him do open heart surgery. And at first I was like, I was going to faint and fall over when I first saw it because it's not easy to look at first.
Right.
When they first start cutting into the chest and everything that goes with it. But then after all, I got fascinated by it. And then I went back on a second occasion and did the same thing again. And I just decided at that moment I wanted to be a doctor. And I was a sophomore in high school, and everything changed for me. And my whole focus became about getting to medical school. So that's how it started. Psychiatry, though, is a different part of it. When you're a third-year medical student, you rotate through all the specialties of medicine, at least most of them. And about halfway through my year, I think it was December maybe, I was rotating through psychiatry, and I had no idea what that was or anything about it really. It wasn't even on my radar to go into. And I ran into this senior resident who was extremely gung-ho about it, saying it was a very successful specialty and it was really good. And I started looking into it, and I made a decision one day that's what I was going to do. And I haven't looked back since. I've never regretted the decision. It's about taking care of people, and that's kind of what I'm about. So I've been doing it ever since. I've been in private practice now for 35 years. I've practiced in the Boise, Idaho area and have been staying in one spot. I've been in every area of my specialty. I've done outpatient work forever, inpatient work forever. But I've also worked when I was a resident moonlighting, I worked at a state hospital for 3 years covering. And then I part-time worked in Idaho's state penitentiary for a year, part-time, because we had a contract. So I went out to the yard, and I went to these different levels and saw death row inmates. And so there really isn't anything I haven't come across. There isn't anything I haven't seen that sort of shaped who I am today. I had this really good training at Iowa that was, at the time in the 1980s, probably, I think, the best program in the country at the time. So I got lucky to fall into that. And then I was able to build on it for 35 years by being very, very busy, seeing lots and lots of people. I don't even know how many I've seen. So that gives me kind of this impetus to kind of share this knowledge. And I've always wanted to point someone to a book, like my patients to a book, and say, well, read this. It's going to help you understand mental illness better. But I couldn't point to that book. I couldn't find that book written by a psychiatrist. There's plenty of self-help books and this and that, but there was no general book that could help people understand what mental illness is and the various conditions that would go in that umbrella and what they look like, what they feel like, and what the experience is with those illnesses. And so I was complaining about it. I said, well, stop complaining and do something. So I decided to write a book. And so it's sort of my legacy to write this book. And it's meant to be a book that resonates with people, not just be a textbook about facts and criteria. It's a lot less about that, although there's plenty of good information there about the brain science, what we know. But then there's 6 chapters on individuals who struggle with a condition like depression, bipolar, schizophrenia, OCD, borderline personality disorder. Each chapter is devoted to an individual. Now, these are fictitious, but they are what we normally see in a regular practice. And it's kind of their journey from experiencing the illness and how long it took to get into treatment, what the treatment looked like, what the after treatment looked like, what the family experience was around it. And each chapter provides a measure of hope for their condition, that it's not all hopeless, that they actually can get better or experience an improvement in their condition over time. And then the latter part of the book is about how families can, what tools do they need to support someone who has this? How do they talk? What's the language that they use? Resources. I have a huge appendix at the end of the book that gives every possible resource you can think of for people. What books to look up, NuMe, the National Alliance for the Mentally Ill, chapters, everything you can think of. So someone has, if they pick up the book and read it, first of all, it's going to resonate. Secondly, it's going to be a massive resource. And then if they themselves have mental illness, it's a good one to give to their loved ones because they will understand it better. They'll speak better. Because what tends to happen is there's a lot of shaming or judgment that goes on. And that is a barrier for people wanting to get help because they feel bad about it. And so the book helps with all of those things. And the true test has been, I've had it out about 3 months now, and I work at a psychiatric hospital every day, and I have had about 30 or 40 copies out on the units, and every day I get stopped by a patient, how much of an impact it's had on them, and how much they now believe they should be in treatment, they should follow their doctor's advice, as long as, of course, it's good advice, and I'm going to stay in treatment the rest of my life, and I'm okay with that. I'm okay with who I am. So I think it's had the impact I wanted it to have, and I feel real good about it.
Oh, that's wonderful to get that response from your book, and from people who would matter in that sense that, you're not getting some accolades or, peer review or, peer, acceptance. It's coming from the patient, which I'll have a question for you later, that relates to that, but I'm going to pin this thought about patients, accessing information to what they're going through. But I have a couple questions from what you have been saying. And firstly is personal. You went to the University of Iowa. I had a uncle who was a professor. Did you ever know Karl Klaus? He was, I think he was in linguistics. I think he was he it wasn't literature. It was a linguistic. He was a linguistics professor. As I stumble over the word linguistics.
Did he work with speech impediments at all, or was he not speech therapy? And more linguistics.
More theory, I think. Yeah,
okay.
It was language. But Karl Klaus.
I might have heard that name.
Okay.
They have a really strong linguistics program. They have a really strong speech therapy program.
Okay.
I lived in the heartland of all that growing up in Iowa City. Okay. 30,000 residents. Or no, 50,000 residents and 30,000 students. So, and then you have grad students and professors. The University of Iowa Medical School is the largest teaching hospital in the country because it serves the entire state of Iowa.
Right.
So I was surrounded in my neighborhood with professors and professor kids, and a lot of them had like the Van Allen. He's the one who had the Van Allen belts that are famous around the earth. He's the one who did that. He lived just across the river from us.
Wow.
Those are the kind of people that were in my little community.
No wonder you went to school and got a good education.
that was part of it. There was a peer pressure thing. When we were in high school, when we talked about graduating, we always meant graduating from college. That was always the expectation, not high school, but college. Right. And so I can give story after story of my high school and my elementary school classmates. All of them have gone on to be esteemed people in their field. So it's pretty crazy.
Very nice. And then I had another question. When you were working with the prison system or the penitentiary system, and someone might hear that you were working with death row inmates, and I was wondering if there's some ethical normative that the state was trying to make sure that these people were, despite being in their place, that they were afforded that modicum of care, or so what was their stance? It was a state prison, or was it a federal prison?
State prison.
State. So, okay. So what do you think the stance was that, these people are condemned to die, and to provide them, which I think is great, but to provide them psychiatric care is interesting on first reception. So what would you intuit that was the motive for that? Why would they have that program?
Well, I think you touched on it. I think it is a statute of some human level of dignity that they're still entitled to food and water and shelter and medical care.
Right.
Psychiatry is a type of medical care. So withholding medical care from even inmates would be considered unethical.
Yeah.
And so that's the case. And, I had quite the experience in the prison with the system. The system is where my eyes were opened. The system's kind of broken a lot. And so sometimes I saw an instance where the guards withheld insulin from a diabetic patient just as punishment, so they would go into a seizure. They did that on purpose. That's of course against the law and against everything. I actually went to the warden and said, this isn't okay.
Yeah.
I've seen them do that with psychiatric patients where they'll remove their psychiatric meds just so they'll go crazy. So that's unethical, no matter who the human being is, no matter what their crime is. They deserve some level of ethics.
Yeah.
Now, they still have to pay the price for their crime, right? They're incarcerated in a terrible place, or they're on death row. So they're still going to pay their price. But I've always treated everybody with dignity, no matter who it was, whether they were a death row inmate or whether they were, I saw them at the hospital and they were terribly sick. I treat everybody with the same amount of dignity. Yeah. It's not for me to really judge. That's not my role as a doctor. My role as a doctor is to take an oath to take care of people, no matter who they are.
Do no harm.
Not if I don't believe in their belief system, that doesn't make any difference. I still take care of them. I still take care of the people in front of me.
Yeah. Well, without trying to be too inflammatory, I would say that the behavior of the persons who withheld insulin or psychiatric medication are expressing a level of sociopathy that is maybe on par with some of the people that are in there who did things.
No, I would agree with that. And I had an instance also where we rounded on these different cell blocks, and in each case they would have a medical office that we would meet with the inmates.
Okay.
And they're supposed to have a guard on hand, right? Because we can't be left alone with inmates because we don't know what we're getting into. On one occasion, what happens? I go round to one of these cell blocks. I go in there, and there's a little waiting area, and then there's an office. But the office has sharps in there, like needles and things. The door's open. There's inmates in the waiting room. No guard. They just leave me in there.
Wow. Yeah.
And that's what really teed me off. And I was another instance where I went straight to the warden and said, this can't happen.
Okay.
But we ended our contract and we did not renew it for good reason. And it wasn't because of the inmates themselves.
No.
I didn't mind taking care of the inmates.
Right.
It was the system that I didn't like. The system was broken.
Yeah.
It's scary,
it sounds like
and very scary.
It sounds like it. It sounds like the view that those people in there are a lost cause perpetuates this almost Pygmalion type thing where, it's a lost cause environment that's going to have lost cause stances and behaviors and things like that. So I can see how it's kind of self-perpetuating. And it's not anything to laugh at because it's if somebody committed a nonviolent crime and they're immersed in that environment, then the abuse beset upon them.
You have to remind yourself that these inmates have a mother and a father. Mm-hmm. They have siblings. They may have children. They're still human beings. They may have done something. Not everyone's done a heinous crime.
Right.
Someone might be there for a non-heinous crime, or because of their mental illness, they didn't have good judgment.
Right.
And when they were off their meds, they did something that they just was just not using good judgment because they were off their meds. And so you have to be careful kind of judging everybody. And that wasn't my role. I'm not the judge. They've already been sentenced. They've already had they're paying their crime and they're paying their punishment. So I'm not there to judge. Yeah. And there's someone's loved one there and they care about them.
Yeah, no, there's still humanity there. And this is all, I'm qualifying all of this by saying that if somebody's a monster, they did something monstrous, then it's probably a good idea that at least for that time that they're not out in the public in the milieu or anything. Yeah. Like that.
I'm okay with people being incarcerated. There's reasons for it.
Exactly. Yeah.
But it's how they're treated in incarceration that's the issue.
Now, on a cheerier, rosier note, in your time with that position, were there instances that you felt like you walked home or you went home after work and said, that person may be turning around? And it may be somebody that's just doing a couple of years. And, did you see instances where you thought that maybe what you were doing, other than just sort of being there to sort of be an ethical present, a voluntary presence or whatever, did you have any moments where you were like, that person may actually be changing?
Absolutely. Absolutely. There's plenty of those things.
Good.
It goes from state to state. It varies. Like in Oregon, they have a big kind of rehabilitation approach. At least they did it when I was working. And the recidivism rate was much, much lower. They had much more success at getting people back in society and giving them tools to succeed.
Okay.
Rather than, open the gate and send them out and hope it works out. And then they just come back in again because they can't make it out there. And so it's just better to commit another crime and get 3 hots in a cot, so to speak.
Yeah.
And have at least a roof over your head with some food going on.
Yeah.
So there's a lot to this story. It's not just simple things. There's a lot more that meets the eye, for sure.
Yeah. Well, little by little, hopefully there's some progress in that you can kind of, make the right decisions. That, again, if there's somebody who's just is completely antisocial, completely psychotic, whatever, good. Yeah. But if there are people who are capable of reformation, which was the whole point of penitentiaries, was to, get this reform, beyond just praying or whatever, that can be afforded to them.
And we can identify who we think has a good chance of being rehabilitated, and those we don't think can be.
Okay.
If they have solid antisocial personality disorder, it's highly unlikely they're going to be able to rehabilitate them.
Okay.
Because that's so entrenched in such a solid personality, and they don't have remorse. They don't feel those feelings, so they're just never going to change. So those are the ones that are hard to say they're going to be ready for society and do just great out there.
Right.
But that's not everybody in prison. So might be a strong majority, but there are some that aren't. We jail a lot of the mentally ill, unfortunately, for sometimes they can't, they don't have judgment when they're off their meds, so they get into trouble. Yeah. Whether it's stealing from a convenience store or doing something stupid like that.
Right. Well, thank you for opening that up with me and talking about it a little bit. I know it's not a cheery, rosy subject, but it's part of our culture and it's part of what happens.
It's about the human condition. That's what it's about. We don't have to gloss it over. That's just how things are.
Yeah, absolutely. Absolutely. But we were talking about your book, and the title of the book is Why Me? Your Brain on Tilt. And let me ask you this, because I want to open what your brain on tilt, what you're inferring there. But we just met, we were just kind of talking, and I'm like, come on, have a conversation with me. But if you would like, I can get a copy of your book, read it, and then maybe have you back for another episode, and we can really open the book up figuratively.
I would love to do that, because that'll give you even more insight. So I get you a copy.
Okay.
I think you'll really find it interesting.
Okay. All right.
So
good, because the audience would probably appreciate that, because it's almost a little awkward for me to be like, so tell me about your book, and not knowing a thing. But anyway, that would be wonderful, and maybe in a few weeks or a month or so I can get you back on and talk about it. But let's talk about, because I've heard you talk about this in a little bit of time that I was researching you about tilt. So I think this is an interesting vehicle to talk about as an analogy.
That's what it is. It's an analogy. So the title of the book kind of just came to me in my sleep, basically. I woke up at 3:30 in the morning, and this title was in my head. First of all, why me is a question that most people will ask themselves, no matter whether it's mental illness or they have cancer, they have some medical condition. Why me? Why do I get to have this? And so that's almost like a universal question.
Okay.
The brain on tilt part is in part in reference to poker, because I'm a long-term poker player. So when you get someone on tilt, when you're playing an opponent, you're trying to get them on tilt. I mean, you're getting them off their game by getting them to be a little upset or mad or frustrated. Okay. And when they get to be in that state of mind, they start making mistakes, and they start showing what they call tells. So when you're on tilt, you don't perform very well.
Okay.
So, but tilt can also just mean off balance, right? Being at a tilt. You're like the Tower of Pisa, Yeah. And so the brain on tilt is sort of like an analogy to a mental illness, right? It's off. Okay. Things are off. So that's kind of how it's pretty figurative, but it has multiple meanings for sure.
Okay. And those of us are old enough to remember pinball machines. There was
tilts, right?
Yeah, you get the tilt warning.
Yep, exactly.
Oh gosh, that's funny. Anyway, showing my age anyway.
Well, we had pinballs back in my day too. I'm not.
Well, of course,
I'm no youth anymore.
Yeah. Oh, I remember, and this is a tangent, sorry, but I remember in the arcades when the first video game showed up, and everybody's like, What is this? What is this alien thing? And it was something super primitive, I
remember playing Pong. That was one of the first things I played.
Yeah.
this little thing back and forth to the other player.
Right.
And that was so cool.
Wasn't it though? I mean, that's like I said, you go into that arcade and 800 pinball machines, and then that one little box that had a TV screen. And everybody's like,
"What?"
Not quite sure what that is.
Yeah. That's definitely aging us, really.
Yeah. Oh, halcyon days, though, I guess. So let me ask some of my intuitive questions, and I want to stay kind of in the adjacent to the book. And this is the pin that I think I had earlier. And I interviewed a gal who was in the medical humanities. She used to be at UTS San Antonio, and she had written a couple of different books wherein she was in good faith critical to the DSM lineage, but obviously the latest iteration was, I think, the locus of her concern. And I want to pose this to you because what she was proposing, as probably just not quite a rhetorical question, but a proposition to explore, is getting aggregated anecdotal information from patients themselves as input to a future DSM or a modification to the current generation. And so, like Wolfram says, the plural of anecdote is data kind of thing, with obviously all the proper guardrails and qualifications. So I guess to ask the question more succinctly, if you can populate input from people with schizoaffective disorder or schizophrenia or bipolar condition, and aggregate these kind of anecdotes or responses or narratives, and then, you know, again, with the right discipline application, do you think that that would have value for future psychotherapists to say, you know, out of 100 people with bipolar disorder, you know, we were able to aggregate X, Y, and Z from this, and that seems to, you know, sort of correspond with, you know, what we see as, you know, the behaviorist or the person looking from the outside, almost second or third person. So what do you think about that? Like, what do you think about patient involvement in a very, you know, sort of rigorous and controlled way to help therapists or psychotherapists or psychiatrists with diagnosis and treatment, et cetera?
Well, let me see if I follow your logic here. I'm trying to decipher what you said.
Yeah, sorry if it wasn't
it's sort of almost like the patient themselves gaining insight into their disorder, whether bipolar or schizoaffective disorder, and providing that input into their therapy or with their doctor. I don't know if I caught that right. And you mentioned DSM, but DSM is a highly evolved criteria for us to talk universally with each other as psychiatrists or whatever, so that someone in Europe and someone in the US could talk to each other about the same disorders and they're using the same criteria. That's how that evolved.
Right.
That came out of a long Freudian era. And I was trained in the 1980s when most of the programs were still psychoanalytical psychotherapy. Iowa was one of the very few biological programs in the country, and it was probably the number one program. Okay. But Dr. William Coriel and others were instrumental in helping shape the DSM by using rigorous studies where you could use fairly large sample sizes of people and look at patterns of symptoms over time and see if they were predictable and see if you could see that elsewhere. And other universities could then replicate that, and then we could start talking about the same condition. And so that's where the DSM became super important. And it influenced my look at how I diagnose people, how I look at people. And so it's a combination of, do they meet the criteria? Like, say you're bipolar and you have to have at least one manic episode in your lifetime to be bipolar. And so you have to have either elevated or irritable mood, increased energy, racing thoughts, decreased need for sleep, impulsivity. There's a whole list. And you have to meet at least 5 of those to be a manic episode. If you only have 3 of them, you have a hypomanic episode. So those criteria are very helpful. And then you can start to say, well, they're bipolar. But then if they're bipolar, do they have more than this? Are they hearing voices? Are they paranoid a lot? Even when they're not having mood symptoms, then they qualify for schizoaffective disorder. So it's a combination of criteria, the course of the illness over time, and then even just as important is their genetics. So if bipolar is running in their parents or in their family, it's highly likely that that's what's going on with them, because we have a saying, it doesn't fall far from the tree. So that's also important information when you're trying to make these decisions. The patients having insights always helpful, because they might be able to say, oh, I forgot to mention this. Oh, I have this as well. Yeah. And the more they can participate in providing their own experience, that's extra data in order to say, yep, that confirms my suspicions all along. Yeah. And so that's super important. If you're a psychotherapist, it's important to understand these disorders, because you have to be careful what approach you take, what kind of psychotherapy you use, and what your expectations are. If you think you can somehow cure these illnesses with psychotherapy, you're probably barking up the wrong tree. But if you say this is a good adjunct, it's a good supplement to help them with their interpersonal skills, help them with their communication skills, help them with their cognitive distortions that they get when they're depressed, and help them turn those around. Psychotherapies have been proven through data, through research, to be evidence-based beyond just placebo. But that's usually in conjunction with biological interventions. Right. Not as a standalone. So I think that's where a good psychologist or a therapist will understand that. They don't feel like they're there to take over and we're going to cure you from these terrible illnesses, but we have some tools to give you that are going to help you navigate life itself. So I think that's the role that they play.
Yeah, I think try to further, and I hope I'm not misrepresenting her views and the way and the approach, but it's more complementarity to everything you've just described from the out, some like a third person, almost behavioralist perspective, and I know that's doing violence to the intricacies of what's been aggregated in the DSM lineage. But no, this is more just so affective states being reported, maybe they're hallucinatory, but then again, maybe there's something to be garnered from that. So it's just, what can we extract from, self-report or, the narrative of the patient. And if we have, a cohort of 1,000 patients with X, pathology or X, thing that's going on, that information could just be amended or appended to everything that's already there, that's rigorous, that's time tested, that's has consensus and things like that. So I think it's more just offering that inclusivity as again an adjunct to or an adjuvant in the kind of
a skilled clinician is supposed to, at the beginning of an interview with a new patient, ask what they call open-ended questions. So you can say, well, what is your understanding of why you're here today? That's an open-ended question. It's not a yes or no question.
Right.
And the first half of the interview, technically, they should be doing a lot of open-ended questions. What that allows is for the patient to open up and not feel judged or narrowed down very quickly. And so if you can do open-ended questions, you might hear something you didn't expect to hear. And that's sort of along your lines of letting the patient share their narrative. And that's what open-ended questions do, is it's not defensive. It's puts them not on the defensive. It's like, I just want to hear, what's going on here. Tell me what's going on. What brought you in here today, or what's going on. And they might say something like, oh, my wife, she said this to me, this is so. And then you go down that rabbit hole and, what do you mean? What did she say exactly? And then see, that's an open-ended question. It's not a yes or no question.
Right.
I'm not trying to steer the conversation. I'm just trying to see what comes out. And sometimes by doing that, you hear something in their conversation that you make a note of and say, I'm going to address that more specifically when I get a chance. Because it might mean that they have OCD, maybe they have bipolar because of some of the stuff they're saying. And so it just allows you to make sure you don't miss anything. And it also creates rapport, right? They'll be able to talk about things and not be judged or anything. They're just being heard. Yeah,
it builds that trust. And then as you get further into the therapy, you get that sort of transference, countertransference that can be good forms of those patterns, but so that you're sort of bonding in a way, I guess, to
you're creating that therapeutic alliance.
Okay.
That's what's referred to as.
Oh, okay. I'll make a note of that. I was trying to put
therapeutic alliance. That's what's referred to as. You're trying to create that rapport that creates a therapeutic alliance between you and your patient, so that there's some level of trust between the two of you, so that no one's holding back, so to speak. And they can trust what you're saying, and you can trust what they're saying. Okay.
But to speak to that therapeutic alliance, and what I probably was misusing when I said transference, countertransference, can the transference, countertransference bump up against that therapeutic alliance? So in the throes of a therapeutic relationship, that, things, especially maybe from the patient's end, they're going to start seeing you as an archetypal role of X, of whatever, as the intimacy unfolds and the patient revealing themselves or making themselves vulnerable or discussing, whatever dark things may have happened. How does that alliance stay? How does it self-correct? Like, how does it stay in that valence that you need?
I think there has to be some level of trust.
Okay.
Because that's the key. You have less transference, countertransference when there's a level of trust.
Okay.
When there's a level of distrust is when you start to see that more often.
Okay.
Like if I feel like a patient's lying to me, I might have some countertransfer, so my body language may express a little displeasure with the patient. Whereas if the I feel like they're being dead honest with me, then I'm going to have a level of, I'll be more relaxed and more trusting, and they'll feel that, and they'll have less transference towards me.
Okay.
Because they can see that there's a level of trust going on. If that makes sense.
Yeah.
So body language, how you say things, how you ask questions, Those are all key, because language and words totally matter in everything, even in not only what I do, but particularly in relationships. You know, you have people say, well, I just want to be super honest, and I want to tell you how I feel. And, well, be careful what you say when you say that. Now, you can be honest. That's nothing wrong with being honest, but just watch how you say things when you're being honest.
Okay.
And because you can hurt someone's feelings when you're being, quote, honest, and it turns into something you don't want it to turn into. And you can get the same message across by using different words. More supportive words, or more loving words, or more warm and, you know, fuzzy words around people, and more building the other person up kind of words. Like, you know, sometimes when you have a criticism of somebody, you don't just start with that. You might say, you know, are you really good at this, this, and that, and this, and that? But I notice sometimes you do this, you know, help me understand that better. That's a little different approach than, I hate it when you do that.
Yeah.
But they're saying the same thing. It's just a different way of saying it.
Yeah.
So with
like you
patients,
said,
it's a delicate little dance, you know. And I'm not always perfect at it, but over the years, I've learned what that dance looks like.
Now, this prompts me to think that in this interplay, that if you're up against, or if you're working with a patient that may be dealing with a particular species of narcissism, or they are sociopathic, that they, you know, are they coming in good faith? Are they probing you and manipulating you, or are they actually, you know, how I know, you know, intellectually how this, you know, the machinations go, but like, how do you set up that, you know, that rapport? How do you establish trust and things like that when you're working with someone who may be struggling to be sincere or in good faith in dialogue?
Well, those are sort of two different things. If they're sociopathic or narcissistic, they're probably not trying to do things in good faith. Because they have no empathy. If someone died right in front of them, like a sociopath, if they were responsible for it, the feelings running through their mind would be, I hope I don't get caught.
Yeah.
It's not, oh, I feel bad about what I just did.
Right.
I feel sorry for this human being.
Yeah.
No, it's how do I avoid going to prison?
Right.
And so for some of them, that type of mindset, to come into a psychiatrist's office or in the hospital and have any expectation for any kind of warmth and empathy or understanding of any kind of human feelings is really not realistic at all.
Yeah.
And so I know that. I've been around it a lot. And narcissism is kind of like that, but it's really this inflated self of ego. And that ego is all that matters. And I'm such a great person.
Right.
And so I don't think they even have total insight into that, and I don't think they ever want to change that.
Okay.
So all you can do is kind of make a note of it and set boundaries. That's all you can really do with individuals like that, is set boundaries. There's no psychotherapy you're going to offer them that's going to give them the insight to finally the clouds part, and I understand myself now, and now I'm a warm and friendly person, and I just care about humans now. That's never going to happen. It's more like, how do we contain these individuals in society? That's why a lot of sociopaths just end up in prison. That's their sort of natural life cycle, is jail and prison. Well, or death.
And is it a myth that there are either self-aware or whatever the opposite of an antisocial sociopath is, like not necessarily a pro-social one, but one that is less menacious and antisocial. So there's this, you know, cliche that they'll go into law or medicine, you know, because they can carve a body up and not, you know, so like high functioning or whatever the right term is for a sociopath that is capable
I call them a white collar sociopath.
Okay. Yeah.
Because they're a little more invisible.
Okay.
But they're not, because if you follow their trail, it's a trail of broken relationships, broken jobs. They end up being embezzlers or end up being dishonest, and they end up cheating people as a white-collar sociopath.
Okay.
And so that's how you see it. And so they can often be, and then they can also be very charming. So they can be very charming. They can charm the pants off everybody.
Mm-hmm.
But behind the scenes, they're really more conniving.
Right.
And they're really looking for an angle. And they could care less about everybody that's in the room. Not whatsoever.
Yeah.
And so I can see it because I've been around that so much my whole life. I know what that looks like and feels like.
Mm-hmm.
But that doesn't mean everybody can.
Right. Okay.
Like, for instance, our current president of the United States is a sociopathic narcissist.
Mm-hmm.
This might turn people off, but that's what he is. And every psychiatrist out there would probably agree.
Right.
And that's why he charms the socks out of certain groups of people and other people see through it.
Mm-hmm.
That's just the way it is. And he's been through 6 bankruptcies. He's can't really create anything from scratch and build it up into something successful,
Mm-hmm.
but he can charm the socks out of people.
Right.
So that's a good example of what that looks like. Is he going to change? Yeah, never going to change.
Yeah.
Never going to. We could talk to her blue in the face about, well, he should just realize. And never going to realize.
Yeah.
All we can do is set our own boundaries. That's all we can do.
Mm-hmm. Yeah. And I was raised by a narcissist. So I, it's when you ask those questions like, oh, how do we fix this? Or, when will they change? Or, I always say it's like expecting normal from abnormal. You're not the alchemist. You're not going to convert anybody into that. So yeah, it's an unfortunate, and speaking to this penultimate, leadership role, and it seems like that people, these white collar sociopaths, do tend to ascend to these positions of power and so forth, where they feel, I guess that's their environment or the ecosystem that they prefer. But yeah, it's a shame because everything is a means to an end, and everything is transactional, and that. Yet the narrative of whatever structure is good faith, and we're supposed to have these normatives and rules and ethos and all this kind of stuff. So yeah, it's very very mixed up, and it's unfortunate.
Well, the path to the top can be lonely and ruthless.
Mm-hmm.
And sociopaths are okay with being lonely and ruthless.
Yeah.
Because that's how they're wired.
Yeah.
So not everyone,
right.
But it almost takes that to get to these levels. We sort of put them on a pedestal, but we got to be careful what we're putting on a pedestal.
Yeah. No, absolutely. I've always joked that I want a sociopath as an attorney if my life is on the, if I'm defending myself against something, it's this faceless threat that's out there. It's like, get him, sick him. Yeah. It's kind of cold. Yeah.
No, I know. We always feel like we want the bulldog, the pit bull attorney for representing us. And there's something to be said for that. But then I also know some attorneys that are very, 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 very intelligent. Mm-hmm. And they know how to manipulate a courtroom. They know how to manipulate a judge based on trust,
mm-hmm.
based on this is a trustworthy attorney. What comes out of his mouth is absolute, and I can believe it.
Mm.
And I've seen that with an attorney, and not in my life, but in a family life. Incredibly great defense attorney, very compassionate, very trusted by the prosecutors and the judge.
Mm-hmm.
So he's able to use that as a tool to get the end result that he wants.
Mm-hmm.
Maybe some more than the ruthless attorney that comes in. And the judge and the prosecutors all know that ruthless attorney. And so they may not get much leeway.
Mm-hmm. Mm-hmm.
So there's pros and cons to both. But I'd rather take the highly respected, compassionate attorney that everybody in the courtroom respects.
Yeah. It's almost like that bulldog aggressive, is dissonant in that sense that they don't understand the social glue or the reciprocity that's going on that you just described. And if that's a blind spot to them, then the outcome could be predicated by that, by that.
So you're definitely rolling the dice with a more aggressive attorney.
Yeah. No, it's just a joke. It's kind of like, like mob attorney.
No, I know. It's like I said, sometimes that can definitely work.
Yeah.
And so we've seen that happen. But
yeah, I'm sure. Well, I've got a few folksy questions. It's hard to believe we've been talking for almost 50 minutes now, but I have a few folksy questions for you, and you are a good soul, and you said you would indulge me a couple of questions, and you can say pass, and we can move on to the next one. But yeah, they're just things that in my pathology, in my neurosis, I'm very obsessive, and I love just digging and mining whatever I can from things that I find interesting. And so to ask you, as someone who's been in psychiatry for quite some time, what has the evolution of neuroscience in the last 40 years or so, specifically with imaging and so forth, how is that, first of all, does it inform psychiatry at all? And what are your takeaways from sort of the imaging phenomena? And this might be a segue to talk about brain stimulation and ECT and things like that. But we'll start with imaging, and then maybe you can move into the TMS, is it, and the ECT and things like that. So hand up.
Yeah, so that segues really well into the brain stimulation, because brain stimulation techniques related to TMS, which stands for transcranial magnetic stimulation, came in the forefront in 1985 when Anthony Barker, a physicist in London, discovered the effect where you could take an electromagnetic device and you could stimulate the surface of the brain. And so that was a big, big impact. In 1993, Dr. Mark George, working with Dr. Barker, had the first double-blind placebo-controlled trial showing that TMS actually was more powerful than placebo at treating depression. That was like what I call a watershed moment, when the world took notice of TMS, and the research around the world exploded. And there's probably been well over 100,000 papers published worldwide related to TMS. As part of that journey, scientists had to understand the brain better. Mm-hmm. Like, what's going on? What is this doing? What's its mechanism of action? Are there other targets? Are there other places? Are there different frequencies? Are there different protocols? It's just this myriad of questions. You open one door and you have 10 more to go in. Mm-hmm. And so as part of that, in 2011, scientists developed a new kind of scanner, a brain scanner called a connectome scanner. You can look it up on Google. Mm-hmm. It actually scans the brain's white matter tracts, which are your nerves. And so rather than looking like a traditional brain, it looks like a hairy brain because it's all these white matter tracts. And then they could start to see where they go. And then scientists started to further deduce that the brain is made up of circuits. Mm-hmm. And so one part of the brain can go to another part of the brain, and they have a feedback loop. In fact, scientists have described at least 17 unique circuits in the brain now. Plus, there's higher levels of functioning, like the salience network and these different networks in the brain that do different things. Mm-hmm. So there's been a tremendous amount of progress using fMRI brain research, MRI research, connectome research, PET scans. All those sorts of scans have all converged in telling us the brain. We know so much more about the brain than we ever did. Mm-hmm. With TMS, you have a beam of stimulation. It stimulates a part of the brain on the surface. But because of the connectome, it's connected deep into the limbic system. And we know that for a fact because MRI research, just brain imaging, has shown that the amygdala in the limbic system actually gets bigger in successful TMS treatment, mm-hmm. which is an anatomical change. We've never seen that before. And so scientists went further. So why is it getting bigger? What's going on in the brain that we get bigger? Because we're always talking about chemistry, mm-hmm. but not anatomy. So they took neurons in a dish and they gave those neurons TMS, and they looked on a microscope before and after, and they noticed that the number of connections between the cell bodies, the neurons, increased in number statistically. Mm. So now scientists have concluded that TMS causes neuroplasticity, mm-hmm. actual growth of more connections in the brain, and that would explain why the amygdala gets bigger. And so there's all this kind of research, there's all these findings. It's just really fascinating. And some of the best minds in the world are working on these problems. So there's new protocols, new frequencies. There's the SAINT protocol that Stanford came out with for the treatment of depression, where they use TMS in a different way, a novel way, where they can get people well in 5 days. It's highly involved, and insurances won't cover it, but mm-hmm. it does work. But it also just tells us all these different ways that we can understand the brain better. Mm-hmm. So there's been a tremendous amount of progress in the last 10 or 15, 20 years in terms of brain science. Okay. And when I go to these international conferences, I hear the world experts, and I'm just blown away. I feel like I'm still back in kindergarten trying to learn new things when I go to these conferences, because they're really working on cutting edge things.
Wow. Yeah, no, that's exciting that to get that convergence with these technologies and steps that we've made. So thank you for sharing that. I interviewed a physician in South Carolina, Baron Short, and he works with TMS.
I know Baron.
Okay.
I know Baron. He works with Mark George.
Okay.
I met him in Barcelona, Spain at my first major international TMS conference. I really like Baron.
Yeah.
Mark George is the father of TMS. He's written 6 books, 250, 300 scholarly articles. He's the one who published that 1993 double-blind study on depression and TMS. He developed TMS with Anthony Barker in London.
Okay.
So that's where Baron comes from. He worked with Mark George.
Very cool. Very cool. We just closed the world in a little.
That's a small little world. I hadn't heard that name for a while.
Yeah.
But yeah, that's the epicenter right there of TMS research and the information out of there. Everything I know about TMS comes out of those kind of places.
From that camp. Okay.
Yep.
Okay. I had Baron on because he and a partner just developed this wearable system that's not as penetrative as TMS, but it's they call it Zendo, and it's supposed to help you just sort of for meditation. It's supposed to help you get into a drop in that's a little bit faster, a little quicker at getting the cortex to slow down, or get things to just kind of relax a little bit inside and get you in not quite a jhana state, but just like a nice chill vibe. And my wife's been using it, and she really appreciates it. I hadn't meditated in a long time, and I did find that it's good for bringing you. I call it like not quite dropping in, but just sort of like letting go of certain layers of cognition or whatever you want to call it. Like awareness.
That gets into the brain wave science,
yeah.
Where the brain has these different waveforms, and so they have these devices you can put on that sometimes help you maybe sync up better with those types of brain waves, and helps with meditation and relaxation and things like that.
Yeah, I need to get back in myself. I did it for years, and I started not quite depersonalizing, but I was just being a little more vacant than normal. And I said, well, let me stop, because I was going for like an hour at a time. I was really just dropping out into this sort of minimal self type thing. And it was wonderful. But then I started realizing that I was kind of dissociated. So I said, no, let me.
Did you shave your head too, or?
No, flowers at the airport. Yeah,
yes.
Not quite that far.
Not quite that far, okay.
But it was very relaxing, right?
Yes. It was working.
Yeah, it was, because I'm very hyperactive.
Proof of the pudding right there.
Yeah, exactly. So I have another even kind of more out there question. Kind of out there. I interviewed Tom Elliott, who's a professor at one of the universities in Copenhagen, Denmark. He's a Brit expat that lives in Denmark, and his whole field is in the holobiont. And so in the conversation I had with Tom was some of the reciprocal neurochemistry maybe that's going on with the constituency of gut flora and, the way that that's working, not necessarily on the neurons in the stomach.
You're talking about the microbiome, right?
The microbiome, yeah. And that there is some stuff in the literature about autoimmune conditions being informed by that, and maybe even some presentations that may be psychiatric, or they may be, psychological or subclinical, that are influenced by that. Have you seen anything in that, or does that interest you at all?
Oh, no, it interests me totally. The microbiome has been called the second brain.
Right.
The gut has the same exact neurotransmitters as the brain does. And the microbiome weighs 3 pounds, just like the brain does. So they're the same size in mass. They're not all in one place, but when you take the entire weight of the microbiome throughout the gut, it's about 3 pounds. And these bacteria have somehow evolved with humans for a long, long time. So there's some sort of symbiotic relationship between the microbiome and us. And the health of the microbiome is really important. They have shown studies where if the brain is not functioning well, then the microbiome is not functioning well, and vice versa. So there's a lot of hot research going on related to that. I do believe there's some substance to it. So I'm very fascinated by all that stuff. And I think
Okay.
because maybe we can also help regulate our brains a little better by having a healthier microbiome. Well, first we have to define what that means.
Okay.
What's the ratio of good versus bad bacteria? What are good bacteria? What are bad bacteria? And I participated in the American Gut Study, where you submit a sample of your gut, and then they do an analysis of your breakdown of your bacteria in your gut, and it compares you to your region, to your country, to the world, and it gives you feedback. And I think as we get millions of people participating in studies like that, we'll start to get a clearer picture of what seems to be healthy and what seems to not be healthy. So it's ongoing research that I think is terribly valuable, for sure.
Yeah, absolutely. And it is staggering. I think one of the little cocktail party trivia things that I could pull out is, and they've changed the ratio recently, but there's like a trillion or so of our endemic cells, and then there are like a trillion or so exogenous extra species cells that we co-occupy this Markov blanket with or whatever, but that they're more prokaryotic, and so they can tinier little things, whereas we're more eukaryotic in our constituency, I guess. But it's fascinating. It's like nearly a 1-to-1 ratio of what we call us, our human cells
in the foreign cells.
Yeah, and the exogenous, non-native.
So that is a hot area of research, and I'm fascinated to keep my eyes on it. I've been watching it for a while. I believe there's some definite relationship between the two, and the science is already showing that. So it's just a matter of time, I think, and AI will speed up some of that analysis, I think.
Yeah, I would think so. Yeah, to sort through all of that, because that's got to be a combinatorial explosion to figure out all the relationships and things like that. So
yeah.
All right, I'll leave one last question that we can actually pin and punt down the road into. If I get you back as a guest the next time, I may send you an article or something from the literature for you to look at and then give me your opinion. But as I mentioned before we went to record, that in the domain of cognitive science, there are lots of interesting rumblings about the nature of, again, how we palpate. This system palpates the world and through sense data and all that. And one of the things they talk about is this kind of there's the fancy terms for it. There's free energy principle. There's predictive processing. There's active inference and things like that. And it's basically just a formalization of our placing bets on what's going on, what's the next thing, and updating our priors and things like that. I don't know if there's any convergence with psychiatry, but I think in the field of psychotherapy, that understanding how that functions, the structural, functional, organizational aspect of predictive processing, to me is fascinating. And it does, you have to, take it all with a grain of salt, but I may pass some things along to you and see if you want to take a few minutes and look at them. And then maybe when we have you back on, you can say, because it all goes around this 4E cog side. It's the sort of flavor of the decade or the last few years in terms of having an explanatory model for cognition itself, which is, an integrated process and so forth, which is E's are embedded, enacted, embodied, and extended. So it's a comprehensive, and you've got enactivists and, but the embodied cognition doesn't seem terribly controversial after we were just talking about the holobiont, where we have the neurons in our gut. And again, every nerve cell is contributing to the picture that's being formed. So anyway, I may not ask you a question about that, but I'll just leave that as a teaser for the audience that I may send you a couple of articles.
Yeah, go ahead and send them to me. I'll see if I can form any opinions about it or not. There's certainly lots of areas of endeavor when it comes to the brain, neuropsychology, neuroscience. There's the hardwiring, there's the cells, but then there's the consciousness, whatever that is, and still being debated. There's all kinds of areas of the brain that are highly specialized to do certain things, and we know that because if we have a stroke in that area, we see what the deficits are. So we've been able to sort of parse out the brain over time to try to understand the different areas, but then how do they relate to each other? How do they talk to each other? How do they, who dominates, what part of the brain gets the dominant over another? Yeah. So there's just a lot there. And so that's just the fascination of the brain. It really is the last frontier in some ways.
Do you have a horse in the race on consciousness, or are you kind of agnostic and it's happening, but.
Well, it's there's just a lot of theories. from quantum science to quantum particles to quantum this and quantum that. And then I just saw something the other day about this other theory. And so a lot of them could be true, but I'm still a data guy. And so until you can show something and it's replicatable and it's demonstrable and you can see results from making a hypothesis and testing the hypothesis, that's where science comes in. So, but it's okay to have theoretical constructs because that leads to possible studies, and possible studies could lead to answers or no answers. And that's how science works. It's fits and starts and revolutionary ideas. And the whole idea of TMS was a complete accident.
Oh, yeah.
Dr. Barker had a Michael Faraday coil, looks like a donut. And that's been around since 1832. And he got permission from his department to put it on someone's head and turn it on. And he got the right hand to twitch. Completely just, you never knew what he was going to get. But it was lucky because it's a diffuse beam. So he could have got the whole arm to move at that point. But that was the discovery. And that led to just a massive amount of brain science following all that to go down this deep rabbit hole. All because of a tinkerer in London with an idea. That's how it starts.
That just prompted something for me. When we look at something like Parkinson's and the compromised substantia nigra or whatever's going on with that, is there electromechanical? I know there were some therapies that have just recently been introduced or being brought in to work with Parkinson's to try to mitigate some of the tremoring and stuff like that. And again, I could be dead wrong. I might not just be this.
TMS has a protocol for Parkinsonian tremor. I haven't used it, but they have a protocol. I don't know how effective it is. That's not totally in my area, but it's a very specialized thing. It's the substantia nigra, it's dopamine. It's really that's pretty much what Parkinson's is. And so that's why I'm a little skeptical, just on the side note, of Michael J. Fox, because he doesn't have the Parkinsonian tremor or the progression of the disease. So I've always questioned that diagnosis as well. Then what part of his substantia nigra is causing what he has? He has more choreiform movements, involuntary movements and writhing and stuff like that. That's not Parkinson's. So I don't know where that came from.
Interesting.
So that's why I question that.
Is he stable in that, or is he degrading? And I don't mean to speak cavalierly about his condition, but I mean, he's been...
Well, he did degrade for a long time. I don't know if it's leveled off or not. I know I saw him on the Actors Award show last night. They panned to him. They talked to him. He seems, maybe over the last 10 years, to be about where he's landed. With Parkinson's, it's a slow deterioration. You start with a little bit of a pill roll tremor and a little bit of slowness and a little what they call micrographia, and then a little shuffle, and then you get some dementia, and it's a downward slide, and it's like almost like a line. So we're not seeing that with him. Yeah. And I don't see the pill roll tremor. I don't see the Parkinsonian shuffle. I don't see the micrographia. Those are all the things and it's just the substantia nigra. It's just one little area of the brain. Yeah. And there's no other, the other part of it. So I question that one.
Okay. Thought I had something else. For me, I'll go back to consciousness for just a second. And for a simple folksy guy like myself, and I've interviewed a lot of people who do philosophy of mind, and they have, like you said, there's 5 or however many theories out there about consciousness. What I've sort of resigned myself to, in having talked to a couple of people who are doing biology, there was an MD PhD student that I had, and she was training Stentor cerealis, which is a single-celled animalcule, habituating its behavior as a single-celled system. And Mike Levin, who's a biologist at Tufts, he has xenobots, which is Xenophus flavus skin cells, that he did some kind of ion channel tweaking in the cell and was able to activate motility with the cilia on the skin cell and habituate that behavior. But the fascinating thing with that guy was he was able to get kinematic self-replication from inert cells, from the active to the inert. So the active just recoded. And so anyway, to get to a point that those single systems, these primitives are palpating the world. They are, aversion and attraction and things like that. That, if you complexify a heap of cells like us, I love to think of consciousness as a verb, more it's verbing, it's consciousing, and the system is consciousing. And this is a cheap out, but it's like, the sensory organs that we have just brought us to where we are, where we have this incredibly, amazing thing going on. And I don't want to be too dismissive of the amazing.
That theory is probably as good as any.
Yeah.
It's almost like looking at like a flock of starlings, right? How do they all move how they all move in one unison thing? It's like it has consciousness, right? So our cells are they are an analogy to that, where they're all connected and somehow they all contribute to this consciousness thing. So who knows? Again, it's fascinating for sure. We know we're conscious beings. We just don't know exactly how.
Yeah. No, and I love that it's a mystery too. We can't solve everything,
We got to leave something.
That's right. Well, what I'd like to do now is, and we can take as much time as we want, is to ask you if there's anything in this conversation that we didn't cover that you would like to bring out to either be summative of the conversation or, pick up on something that you may want to tie in to something we talked about. Or if we want to just go ahead and wrap it up, we can do that too. So I'll invite you to just whatever you feel good about. Let's bring that out, and then maybe
I won't go into too much because we should wrap it up. But obviously the book I wrote is really a summation of my view of the world of mental illness and what to do about it. And it's humanized, and I feel it's very impactful. So go to the book, get the book first and foremost. But I think I'd love to do another time when you've read the book and we can talk about it in more depth. And I think that'll be very instructive and helpful. And I think I'm curious to see what it does for you and what impact does it have on you, because you're very curious, you're very self-taught, you're very smart. I can tell all that. And, let's give you some more ammunition to talk about.
And I'm happy to admit that I have issues, so it may be revelatory. Okay. No, right. That's
cool.
It's all out here. Yeah. No, I've got my stuff, and that would be fun to see that, the interplay with the book and just to mirror, that for myself. And I'd
like to see what experience you have with it. That would be important. It's okay to be vulnerable and talk about something. Let's see what relates to you and what doesn't. What do you connect with? Yeah. So why don't we plan on that? And
okay, wonderful.
Then we'll do something like that. Just reach out to me and we'll figure this out.
Yes. We'll do that behind the scenes, and then so to the audience, there will be another episode coming up where we'll talk about the book itself, and I'm looking forward to that very much. Dr. Kent, I really appreciate your time and what you've provided for us, and the work that you've done for your book. You just know it's going to impact lives in a positive way, and what better legacy could you leave the world to be in service to the world, as you've chosen in your career path and your medical career. So I want to just acknowledge that and thank you for that. And I look forward, again, not to be too redundant, but I look forward to reading the book and talking about it. So
okay, we'll chat behind the scenes and we'll figure this out.
Absolutely. I'll say goodbye to you when we're done with when I stop the record. But to the YouTube and the Spotify audience, thank you all so much for being here and for your time. And I hope there were some good takeaways for you. Links for the book and links to Dr. Kent's website will be down below in the description field. And if you're on Spotify, whatever iteration of description is there, I don't really know, but anyway, you can find it there and access it. So that'll all be available to you. So thank you so much. And again, maybe in a few weeks, hopefully like April, maybe sometime in April, we can get Dr. Kent back on and have a conversation with him about the book. So take care, everyone.